Snoring, quickly as I can. Anybody got, look around, is anybody asleep, or can I go on with this one? Okay, snoring. Objectives. Let's talk about a protocol for treating snoring. Let's talk about measuring a snore. Let's talk about oral appliances for snoring. And let's talk about modeling a snore, spectral characteristics, marketing oral appliances for the treatment of snoring. We got to make money doing this. We did the basic definitions. I'm just going to quickly, 80 to 100% reduction of airflow is an apnea. Hypopnea, 30 to 80% reduction of airflow. Upper airway resistance, approximately greater than 30% reduction of airflow, characterized by arousals. Usually with an upper airway resistance, there's an arousal. Effort, you have effort and reduced airflow. Central apnea, no effort, no airflow. Of central nervous system origin, we talked about a mixed. We said snoring defies definition. But in order to have snoring, you have to have three things: vibrating structure, flow limitation, and sleep. Okay, upper airway resistance does not equate to snoring. Snoring implies upper airway resistance because you have the vibrating structure and flow limitation. But it does not correspond temporally with oral nasal resistance. Snoring does not generally cause arousals. These patients that come in, and my wife says they snore. It doesn't bother me, but it keeps her awake. They don't know they snore. And so upper airway resistance does cause arousals. Snoring is obstructive sleep breathing. It's clearly identified. Now there are other sleep sounds, which are stridor, wheezing, and cataphrenia. Wheezing, you'll hear that maybe in one of my slides. Cataphrenia is moaning, and stridor is sort of like a shriek. It's like, it's an inward, but stridor comes from the vocal cords and not the pharyngeal walls. The gold standard definition of snoring has been elusive. Okay, prevalence of obstructive sleep apnea. They say it's 2 to 5%. According to the literature and epidemiological studies, snoring, 40%. That gives us about 20 times the size of a marketplace if we deal with snoring. Snoring is where the market is. Apnea, nice, but if you take the apnea market of 2 to 5%, and even if it's 20% truck drivers, the fact of the matter is that they're going to get CPAP most of the time anyway. We have a very minimal market in apnea. Snoring is the market. So let's look. I did a protocol. I did an algorithm. And I thought, well, I'll publish this, and let's see what happens. I expected 25 letters to the editor. I published it in Sleep Diagnosis and Therapy. And so basically it's this. Chief complaint is loud snoring. Does not have to be the patient themselves. It could be the bed partner. It could be the neighbor. But anyway, here's this patient who snores loudly. So now we take a history. And so in the history we do BMI, we do Mallampati, we do tongue size. You can read this list. We've been through this list all day. Baseline, at the end of this we say, okay, we think, would you agree in our office, would you agree that you need a screening? And they agree in our office usually because the screening is free. We do this as a service because we care about you, because we care about your family, and because sleep is important. So we do a screening. And then we send them home with a metabite for a night, and they come back in. Okay, now, at the end of that night, they either have one of two things. Either the apnea-hypopnea index is greater than 10 or it's below 10. So now, let's assume for a moment that it's above 10. So now you can send them to a sleep specialist. Fine, that's a good service. And you're a prime referrer to the sleep center, and so they respect you, and you express your desire that if at all possible you would like to do an oral appliance, and presumably if it's mild to moderate, they're going to honor that and send them back. Another alternative might be that you send it out for computer analysis by a board specialist, and the board specialist would agree, or the primary care would agree that an oral appliance is necessary. And so that patient above 10 is treated differently than the patient below 10. And so here's the story. Victor Hoffstein, in Principles and Practices of Sleep Medicine, defines a condition called benign non-apneic snoring. Benign non-apneic snoring is defined by an apnea-hypopnea index less than 10. Patients with apnea-hypopnea index less than 10, he says, have no increased risk of coronary problem, heart problem. They have no greater risk of heart attack or stroke. And so and actually he's saying that that's what so the point is, these patients below 10, according to him, are not at greater epidemiological risk for the morbid symptoms of apnea, even the diabetes or the depression. They're not at risk for those conditions. And so he spent a whole chapter on the book, and Kennedy's called Dr. Snore, and he's probably published about 8 papers on the subject, and he's very well thought of. He's very well respected, even in the United States, being a Canadian. And the fact is that we now have a condition I want you to think of as benign non-apneic snoring. And so for the benign non-apneic snorer, we make an oral appliance. And the oral appliance is then delivered and tested. And so we do a follow-up metabite study. If it's successfully treated, the snoring is gone, or the patient, you play the snoring and it's negligible and everybody's happy, that's called successful treatment. So let's assume it's a qualified success. They're still snoring a little bit, so you adjust the appliance, you maybe do position training, you get them off their back, and you do follow-up metabite study, and hopefully you get rid of it. You treat it successfully. Let's assume after a while you say, well, it's unsuccessful, or let's assume the patient doesn't wear the appliance, and so we have unsuccessful treatment. Boom, they're back on the other end of the triage. So let's assume it's a qualified success for a moment. They're better, but you'd like to see if you could do better. So maybe what you're going to do is you're going to do nasal spray, you can nasal cannula, you could do breathe rights. You put a breathe right on, you say, well, is it restriction at the nasal valve? Is that causing the upper airway resistance? So we think that, yeah, nasal sprays you could do. So again, this is where we get into 2-night studies. And in the 2-night studies, we would use, we say, okay, several things here. It's imagination. This is the typical. We'd say, you got a dog at home? Yeah. Maybe you're allergic to the dog. So we would say, listen, go home and try an antihistamine spray, sleep with the metabite one night, and then you can keep it a second night, and the second night, get rid of the dog. There's several ways we could do. Often we will say, listen, go stay in a motel and leave the dog at home, and you know, because if you have no dog, no cat, and you're in a hotel, presumably there's no allergens. And so that's one of the kinds of things we do. We're trying to be ingenious about this. And so we might say use a breathe right, and use nasal spray, use Afrin spray, let's say. Okay, Afrin spray is addictive, but there's one night not a thing. Spray and see. So say, is it allergy that's causing you the problem? Get rid of the animal dander. Whatever you can think of to do. We might now say, tape the mouth shut and see what happens, because maybe they're mouth breathing. And so what happens is, how hard is it going to be? How difficult? If the mouth is taped shut, that may do it. But is they snoring because the mouth is open? And if they're snoring because the mouth is open, then, and you can get them to nose breathe because the nose really works and they had the tonsils out, or it's something else. So there's all kinds of steps. That's the imagination step. And that's the step we want to hear if you come up with a better way. So we got allergies, we got breathe rights, we got sleep in a hotel, we got all kinds of things here that we're trying to, you know, get them to do. And so this is the kind of use your head type of block. And then eventually, if something works, then boom, they're back for a metabite test. And having had the metabite test, then we're talking about successful treatment. And again, while we can always do metabite tests, and I do, really the requirements are that all you have to do is they think they stop snoring, or the bed partner says they stop snoring. So snoring is different than sleep apnea. Okay, so what do we do? I'm sorry, it's a class 3 ambulatory recorder. I have to change that. Somebody make a note of that. And then it records body position, chest effort, abdominal effort, obstructive sleep apnea, central apneas, hypopneas, oral nasal resistance. It records blood oxygen desaturations, heart rate, snores in decibels with audio replay. It does breath rate, number of breaths per minute, and all kinds of stuff. And so it's a very, very useful tool. And so this is what the sheet looks like. And again, you understand that these here are snores. And depending on how you look at the snore, you see loud, you see quiet, inhale snores, exhale snores, and then occasionally you'll see the flat lines. And oh, interesting thing, remember, an apnea is 80 to 100% reduction in airflow. Again, think about it. If it was really, I think yours averaged 30-some seconds an event, 30-some seconds an event. So how could you not have brain damage if it's 100%? That's illogical. More than likely, what they're calling an apnea is going to be an 80, 85% reduction. As long as you got airflow, you can have snoring. And so I go to the sleep center and I talk about this and I show, and they say, oh, your equipment's no good. We all know that you can't snore during an apneic episode. Yes, you can. And I show this. And then, of course, the head of the department or the head technician, or the head, yes, it's true, you can snore during an apneic episode. And so some of the loudest snores will show up in apneic episodes. It does. Hypopnea, same thing. You can snore because it's, again, is it going to be 100%? Not likely. It's extremely restricted airflow, but the snoring is possible. And so here you look at this one here, and let's say in this picture right here that you can see, if you can see my arrow on the screen, that's a flat line, and boom, there's snoring in it. Not quite as much there. But here's one here, snoring. Here's one here, snoring. Yes, you can snore. Here's another one here, snoring. This looks like quite a loud snore, as a matter of fact. So, okay, snoring can occur, and don't think it can't. Okay, so we have three things. You already know this. You know what a DSAT looks like. You know what a hypopnea looks like. You know what an apneic episode looks like. And you know, yes, you can go into your software. First of all, Rick and Don are way ahead of us. And so the point is, I think this is a couple of years old, this picture, and maybe a different software. And so in this software here, the apneic event may have started here. Is that going to change anything? No. An apneic event's an apneic event. This apneic event is what, 5, 10, 15, 20, 25, about 27 seconds. If it's 17 seconds, because it's here to here, it doesn't make any difference. And you always, time and again, we go back, is just because the patient's a fussy person or you have a reason, and you could do this point by point, and at the end of an hour of your time manually scoring this, you're going to come out with an apnea hypopnea. It's going to be nothing. It's going to be the same or off. Because every time you see one of these that you say, well, I'm changing the length. You don't change the fact that it's an apnea. Or you say, well, this is a hypopnea, not an apnea. Or this is a nothing, and then you'll say, oh, but this apnea is really 2 events in one, because here's a recovery breath in the middle. And so we do this occasionally, and it's just an exercise of futility. This software is excellent. And I think that the software is about as good as I am, or better. So we don't mess with changing the score. And if just, I'm sitting and looking at it, and I'll say, I'll grab it. You grab it just like you would, right click or left click, and you pull it over to where you think it is. If you feel better doing it, do it. But it doesn't change the readings. It doesn't change the data. At the end of the night, the score is the same. Okay. So I went to great trouble to put all these snores in there, and somehow they got lost. Now I'll tell you something. These snores are very impressive snoring. I'm a snore specialist at saving these, talking about this. And this snore was a rip-roaring snore. Just imagine a loud, horrible snore here, because I don't have it. Something technically happened to me. I lost those pictures of the TV, the videos, the little video clips, and all of a sudden my sound seems to have disappeared too now. So basically, here's what you have to see. Natural selection has given human beings a flexible airway from soft palate to the epiglottis. It enables speech, but a definite advantage of problems occur because the airway shares the same passage as the foodway. Now that was a 105 decibel snore. I put it in there just because I never saw a 105 decibel snore. And if you want, we can calibrate it, but 105 decibels is quite a bit louder than that. But it's okay, so you got the picture. The precise relationship between nasal resistance and snoring is complex. When both are measured simultaneously, no significant, well, there is significant correlations. They got better software now, I'm sorry. With snorers, we have higher inspiratory pressures, faster turbulent airflow, and more negative inspiratory suction, increased total inspiratory pressure during snore breaths. But a snore can occur on inhalation. A snore can occur on oropharynx or the nasopharynx. A fundamental reason for increased collapsibility of the pharyngeal walls in snores is not exactly clear. Nocturnal nasal congestion may be a strong independent risk factor for snoring. Patients with complaints of nasal congestion due to allergy are almost twice as likely to have sleep-disordered breathing than asymptomatic controls. So what are the physiologic reasons? Decreased neural output to pharyngeal dilators during sleep. We're talking about genioglossus lucidity. Increased activity of musculus uvula in patients with sleep apnea. And habitual snorers have a higher percentage of hypertrophic type 2A fibers in the pharyngeal constrictor muscles. So dental apparatuses for snoring. They definitely open the airway. They do not appear to improve nasal breathing. They simply allow breathing to occur through a non-occluded oropharyngeal airway. So the functions of warming are sometimes accomplished by the oropharynx. Sensory input from the pharyngeal region monitors airway resistance or effort. Retrusion of the tongue creates a narrower airway, increases resistance, but it does increase warm and filter the air. The soft palate also provides cleansing and moisturizing from the opposing surfaces of the velum, tongue, and pharyngeal wall. But they also dry out pretty fast, so when you're mouth breathing, it takes a lot of effort to keep it moist or it gets inflamed, and then it hurts. You have the red battered uvula. The oropharynx receives moisture from the back of the mouth and the tongue. When nerve receptors within a tissue are stimulated, they cause blood vessels in the proximate tissues to dilate. Snoring causes vasodilation. Vasodilation is the red battered uvula. And so the Moses theory is that snoring may be a beneficial adaptation, bringing about the vasodilation that warms the inhaled air. The red battered uvula may in reality be a clinical sign indicative that the mouth breather's adaptive heater mechanism is indeed working. So one of the things, you know, when I went to Rush and I came up with the Moses, and Dr. Rosalind Cartwright was head of the department, and I showed it to her and told her, and she said, listen, I like this, I'm excited. I'd love to do some research with you. But listen, you know, Rush is not in the best of neighborhoods. It's not nearly as lucrative or wealthy an area as Northwestern, which is right up the street here. And so I said, if you come up with a teaching case, I'll be happy to do the oral appliance gratis. You give me a good teaching case, and it's done. So she takes me in her office. She says, okay, Frank Diaz, the head polysomnographic technician at Rush, has had 25 snoring appliances, and his wife still tells me he snores. No snoring appliance ever worked for him. So I'd like you to do him as my special favor. I'm calling the gift, and I want you to make an appliance. So Frank came in, made him an appliance, and stopped the snoring. So did that do it? Did they all of a sudden my credibility go up? Everybody's testing it. Nobody believes it. They're still skeptics. So Frank Diaz leaves it out for a night. And he does stop snoring. So I see him. He said, I think I'm cured. I don't snore anymore. A week later, he said, 3 days out, and all of a sudden the tissues got red again, and they started snoring. Then another interesting thing, one day he went to a White Sox game, and he had too many beers, and his throat swelled up, and all of a sudden he practically couldn't breathe. that his throat was all swollen. And so he put the appliance in, and the snoring stopped, and he could breathe again. And so this guy plays games with this. But the point is that, like tonight I say, you put it in tonight, you will not in one night cure the redness. Put it in for a week, and the redness will disappear and the swelling will disappear. Leave it out for a night, you can't get that inflammation back in one night. So we're doing something beyond dilating the airway, we're allowing those tissues to heal. And so, I just make the point that the redness is so when I presented my snore theory there, the snoring could be good because it's keeping the airway, the oral airway warmed and humidified. They go, that's really interesting, we hadn't thought about it. We'll have to test it, but that's the end of it. Because testing is hard. Testing today requires a lot of money. I don't have it to give them. Anyway, everyone seems to know a snore when they hear one, but there's no gold standard definition. It's produced by vibration of the soft tissue of the pharynx, soft palate, and or uvula, and actually some of the nasal tissue as well. Usually occurs on inspiration. It can occur on expiration. Snoring can occur during both inspiration and expiration in the same patient, the same breath. And you showed that yesterday. Snoring can occur during exclusive oral breathing. Snoring can occur during exclusive nasal breathing. It can occur during combined oral nasal breathing. And snoring can occur during apneas and hypopneas. So what we see here when we see it is, let's assume this is a picture. And the green is an obstructive apnea. And the red, again, it's older software. I think it's improved now. The SNR is picked up in a more temporal, time-wise fashion to be consistent. I think Rick showed that yesterday in a more time-wise, temporal fashion. So here, it looks like the snore is occurring in the red area first, and then it's occurring differently. But I think the software is improved now so that they're close. They should all reason occur together. Anyway, this is the snore recorded in decibels. And so what you can see is, if you're looking here, as it initiates, it's not quite as loud. And then it gets louder, and then it gets softer, and then it gets louder. And so it seems to undulate, and here it's softer. And this is just in decibels. This is not spectral analysis of the snore. And so as the air goes, look at, then it fades out. So as the air flows through the airway, this airway itself is changing. And as the air itself changes in pressure. And so really, this is like playing a fine musical instrument where as you're playing the note, you're altering the tone as you play it. So the lessons here. Snoring is non-uniform in loudness. Oral nasal resist, well, that's not necessarily true, but a snore can occur in an apnea. Because there's the picture. I'm showing you a picture, and the green is an apnea. Now what we've done is, remember, you can do a 5-second window. And so if you hit the button up in here, and you tell it you want a 5-second window, you can get it. Rick was looking at a 300-second or a 5-minute window. That's a nice window to look at something else. You can also do a 6 minutes, still a 6-minute window, yeah. And so each one shows something else. You look at a bigger area, you get a different picture. But you're looking at different aspects of the same problem. But the point is, so when you look at this green, it's 1, 2, 3, 4, 5. It's a 5-second apnea. It could have been a 20-second apnea. It could have been a 6-second apnea. We don't know. But the point is, here's an apnea, and here's a snore during the apnea, and it's loud. It's loud. And so that happens. Perception of snoring is highly subjective, according to Dr. Hofstein. So why do human beings snore? The pathogenesis of snoring is the vibration of the tissues. 3 conditions are necessary. Things that can cause snoring: nasal polyps, soft palate. You can have vibration of the soft palate. You can vibration of the faucial pillars, pharyngeal walls, the tonsils, the adenoids, the uvula, the tongue. And so there's multiple sources of the snoring sound. Snoring can be generated at multiple sites. The health consequences of snoring range from none, if you have benign non-apneic snoring, to severe sleep disturbance. There are patients here who had, someone at least had a 46 and they snored, and so the snoring could have huge consequences. Certainly, it's not a desirable characteristic. Maybe if we just look at snoring, you got a question? You're scratching your head. Do you need a microphone to scratch your head? Okay. I'll get you one. Okay. So none, severe to severe sleep disturbance. Snoring by itself provides a very low diagnostic accuracy for obstructive sleep apnea. Remember, 40% of all people snore, 2 to 5% have apnea. So something like maybe 80 to 90% of the snorers don't have apnea. So Hofstein did a study in 1996. He took a group of patients who snored and suspected of having obstructive sleep apnea. He tested them, and he found that less than 50% had an AHI greater than 10. So can't predict. Okay, so we went over the chart. Collapsibility of the upper airway is increased in obstructive sleep apnea and snores, but again, as we're saying, it's increased in both wakefulness and sleep. The morbidity of the non-apneic snorer. According to Hofstein's study, there's no difference in blood pressure in apneic and non-apneic snorers. No study has implicated snoring as a risk for vascular disease. Snoring may cause sleep fragmentation and excessive daytime sleepiness, and repeated studies have failed to support an association between non-apneic snoring and decreased cognitive functioning. So then there's an article that we saw, and this is called Heavy Snoring as a Cause of Carotid Artery Atherosclerosis. And so the study says that after adjustment for age, sex, smoking history, and hypertension, heavy snoring was successfully associated with carotid atherosclerosis. How does that relate to what I just told you? Does that make it wrong? So what you do here, and what I did here, is you can take a look at the data. And what you find is that those patients who had heavy snoring had the high AHI. These patients with the heavy snoring and the carotid atherosclerosis averaged a apnea-hypopnea index of 20.21. And those with moderate also had apnea. But the mild, who had an apnea-hypopnea index beneath, didn't have apnea. So for the whole group, the average was barely above 10, but the point is none of the heavy snorers qualified as for the definition of non-apneic snoring. So the paper is irrelevant to what Hofstein said, in my opinion. Heavy snoring in this study relates also to the number of epochs in which snoring occurred, not to the loudness of snoring. So that's another interesting thing. So, in my opinion, while this paper has a title, it looks like it's going to be a killer. Heavy snoring is a cause of carotid atherosclerosis. It really could just as easily be titled apnea as a cause of carotid artery atherosclerosis. And if you qualify heavy snoring as having an AHI below 10, it doesn't carry, it doesn't hold weight. And so certainly the noise is disruptive and annoying. The loudness of the snoring doesn't relate to the pathogenicity or the severity of the apnea. Modeling a snore, let's model a snore. So this is the way I think of things. So I want to model a snore. I want to know what's really happening. So I went to Home Depot and I bought a big rubber hose about that big. And then I took some leftover triad. I had some leftover triad sticks. I played with them and I made an artificial tongue. I cured the thing in a light oven. And so this is my model. So we have a tongue. This is the tongue. And then I've cut a hole so it looks like this is the uvula and this is the pharynx. See this whole area here, and here is the pharynx. And so I have a nasopharynx. I have an oropharynx behind the tongue. And this is the way I model a snore. Let's see what we can come up with. So here it is again, looking at it from the bottom. So here's the here's the uvula, soft palate, here's the back wall of the pharynx, here's the airway right in here, and here's the tongue right here. Okay, now here it is from a different point of view. Here it is looking at the side. So let's say here's the nasopharynx, here's the oropharynx, here's the hypopharynx, and here's the base of the tongue, and there's the base of the tongue collapsing on the airway, and of course the airflow is going to go right to left. And so what we see is that there's a broad base, and the broad base reflects a complex sound. And remember now, the air doesn't go through at the same rate. So as the air is going through, the force of the air going through is varying, and so the force up and down on the airway is going to vary, and the rate of flutter is going to vary. And so this is the way we can do it. So now let's reason a little bit more with this, in that if you take a ruler and you kink the hose and you blow the air through, you're going to get sound that's going to sound like one tone. It's going to be a very simple tone. However, I hit the wrong button there. Okay. Deconstructing the snore. Let's talk about spectral analysis, background information. Okay, that's a snore. This one here, it's here, is a harmonica. That was a computer-generated sound. The computer-generated sound, I don't want to annoy you anymore, but it's 593 hertz. Okay, here's 593 hertz, but it's on a harmonica. Let's see if we can get it. Okay, that's what it sounded like on harmonica. But you see the point, this is a simple sound. And even if it's a harmonica, it's not a pure tone. Okay, and so that's a snore, and you could hear the variation in the tone of the snore. And so look at the spectral power analysis. The power spectral analysis showed a huge amount of sound early on at low tonal rates, and then it showed a tremendous amount at 400 hertz, but the sound went on all the way almost to 1,000 hertz. And so you have a broad tone on a snore like that. And so here's the way you can analyze a snore again. So the software they gave me at the time, now you just take and you highlight the snore. Well, they did a little different in those days, and the way we were analyzing a snore is you would analyze the snore in a square. So if the snore happened over 2 timelines, you could analyze the first half of the snore, then you could analyze the second half of the snore. That's the way you had to do it. And so if you're looking at this thing, the up and down height of the tone is the amplitude, and then the time it represents, like each one of these was totally, it was a 1 second epoch. And so we have the first part of the snore, and we have the second part of the snore. This is pretty cool. The snore pretty much divides itself in the middle. The entire snore traverses a second marker line, and so we have epoch 136 in this picture, window second 8, and here we have epoch 136 and the 9th second of the epoch. And no other snore sound exists in this 1 second segment, and no other snore sound exists in the second segment. So the spectral quality of a snore can vary from the beginning of the snore to the end of the snore. There's the spectral analysis of the first part of the apneic snore. There's the spectral analysis of the second half. So we have a different spectral analysis from one half of the snore to the first half of the snore to the second half of the snore. Okay, here's snores during hypopnea. I'm going to click it, but somehow about this it seems to have missed. I went over this yesterday, and I made sure it was there. And so the point is that here's the same snore in 2 windows, but it sounds like it's different notes being played. This is a spectral analysis of the same sound, of the same snore in different epochs. And so huge variation and spectral analysis occurs between snores in the same epoch. And so here's a 2-second window analyzing the entire snore, but there's another snore from the same epoch. So look at this to this, and you have different spectral characteristics. Okay, so now I did a study, and I studied, I don't know, 1,500, 2,000 snores. And so I selected snores. I compared snores from the first third of the night, the second third of the night, and the third third of the night. Then I compared apneic snores versus non-apneic snores. And then I compared nasally obstructed patients versus nasally patent patients. I analyzed those snores. And then I found huge variation in each third of the night on the same night. So they snore different in the middle of the night than they did at either early night, early evening, or late evening. And then I found huge variation in spectral analysis of snores within the group of mouth breathers. So mouth breathers doesn't say that they snore similar. Then I found huge spectral difference, and no spectral differences were noted in snores from nasally obstructed breathers versus those of nasally patent breathers. And then huge variation in the spectral signal was noted between nasally patent versus nasally obstructed apneic snores versus non-apneic snores, the predominant signals of any snore group, and overall spectral analysis. There's huge variation in the snores of all different kinds, no correlation. Sit there and you look any which way, and no significant difference between, could be identified between the spectral snores of apneic and non-apneic snores, and no significant pattern of snores emerged as significant identification of any grouping of characteristics. The snore is a vibratory event, results from collapse of the flexible airway, rich in its spectral complexity, non-uniform in its duration, loudness, or spectral content. Okay, so I'm about ready to give this up, and then I think of one more thing. And I don't think it's of any significance, but it's entertaining, so I'll tell you. So what I found was that there were 6 types of snores I identified as being characteristic. And now, you have to understand, I'm quite hard of hearing. I need a microphone to hear you, and I'm sitting in front of my computer, and I'm thinking to myself, okay, I can hear differences in the different types of snores. So I identified what I call a wheeze, a flutter, a groan, a roar, a honk, and other. Okay, that's a roar. One more. Okay, and that's what the roar looked like. Then we had a wheeze. Huh? The wheeze. The wheeze is, that's a wheeze. Okay, trust me on that one. Okay, and so that's what a wheeze looked like. And then, you saw this yesterday. I think it was a different patient, of course. But you have a snore on both inhale and exhale. Okay, but then this is what I call a flutter. Okay, so much for the flutter. And this is what it looked like. This is what a flutter looked like. Certainly different than a wheeze, right? Certainly different than a roar. Now we looked into the groan. Let's see if this is here. All right, this is frustrating. That's a groan. Certainly different from the other spectral analysis. Okay, here's a honk. You know what a honk sounds like? This is cool stuff. I'm sorry it's off. It's frustrating as hell. There's a honk. And here's the other. This is catathrenia. This is like a moan. That's vocal cords. Okay, that's catathrenia. Let's look at catathrenia. Other. Maybe a catathrenia. That's other. And so that's the way other looked. Oh, here's other again. It sounded a little like a coyote to me. I don't know. So anyway, the point is that that's what that one looked like. And so each of these has a totally different spectral picture. So I concluded that let's assume that we had a patient and we have a snore. And so let's say, what can I conclude about a patient who has a roar versus a flutter versus a groan? And so just because I hear it doesn't really tell me anything, because that groan could be a flutter at a different time of night. And so the point is, there's nothing. A snore is a sound having a wide and varied range of spectral components. It did not appear that there was a signature characteristic of any snore that could identify it as being apneic, hypopneic, or non-apneic. Snores are different from the same person from the first third, the second, or the last third of the night. They had different characteristics. The first half of the snore is different than the second half of the snore. Different snores in the same epoch have different spectral characteristics. It appears that there was no spectral profile that could identify any category of snores. The sounds analyzed, you could figure out a wheeze from a groan. It's really very hard to think of any clinical implications that could be used because of the other characteristics. And so what can we take away from this? We can take away from this as the fact that there is such a thing as a benign non-apneic snore. And so no studies have implicated benign non-apneic snoring as carrying an increased risk of hypertension, vascular disease, heart attack, stroke, or decreased daytime cognitive function. So that makes it pretty easy for us to treat. It's benign. No one else is going to pay for it. And it's not related to any morbid symptoms. And so what we're saying in essence is that in many cases the patient wants this. They can have to pay for it themselves. All you have to do is get rid of the sound, and you've successfully treated them. And that's what you have to know. Excessive daytime sleepiness has been associated with benign non-apneic snoring. And so why are dentistological health care? Because, first of all, we're educated in respiratory physiology. We're educated in oral anatomy. We're educated in the biomechanics of swallowing. We're educated in tongue function, orthopedic repositioning of jaws. We're educated in oral prosthesis. We understand the consequences and morbid sequelae of diabetes, depression, and obesity. We're capable of taking a good history. We do a good cancer screening. Dentists are examining these patients on the basis of a higher level of formal training than most physicians receive. No other health professional is licensed to make and fit intraoral appliances. So I'm just passing on to you my feeling that if you got benign non-apneic snoring, I treat it. I have no reservations about treating it. I think the literature defends it. And while I expected to see holy hell break loose when I published that article, there was not a single letter to the editor. No one just argued it at all. And so, for all that's worth, that's the story. Benign non-apneic snoring does not have the morbidity of obstructive sleep apnea syndrome. Are dentists qualified to make it? The answer is yes. The Metabite is as close to a gold standard to evaluate successful treatment of snoring as anyone has come, because of the unique characteristics of being able to do spectral analysis and being able to listen to it in decibels and totally analyze it. Okay, any questions? Oh, so there's one other thing here. It's very interesting. Rick's already talked about this and alluded to this. That is the fact that I think they did this because I had a hissy fit. I went to the FDA for approval of this device, and I submitted to them data, just like you saw in the histograms, where the snoring was like this, and then the snoring was like this. And so they said, what, do you expect us to understand this bar graph? I said, yes. Oh, sorry, it's got to be more objective. You're looking at this, we have to subjectively interpret that bar graph of this to this. And so we can't do that. So I called them up, I said, I need help, and I think you guys can do this, and I want it done yesterday. So they did it. And just like that, almost yesterday, because they're friends, because they're dear, and because they value the relationship with us. So what happened is, we start out, and we have a patient, and the snoring volume is 90 to 100 decibels, 0% of the time. You saw this yesterday. 80 to 90 decibels, 2.8% of the time. 70 to 80 decibels, 7% of the time. 60 to 70 decibels, 8.9% of the time. They broke down the snores by decibels. And then we send in an after study, and so while the mean sound went from 71.4 to 65.8, that may not seem like anything. But here's the bed partner. The 80 to 90 decibel snores went from 3% from that elephantine roar, where they're now down to 0. So there's nothing above 50 to 60 decibels, and 1/10 of the time this patient is above 60 decibels, which is really inaudible. And so the fact is they took the snoring down where, in essence, let's say 9 and 9 is 18, 25, 28% of the snores were at an audible, no, let's go higher, let's go 60, 9, 16, and roughly 19% of the snores were rip your socks off, rip the wallpaper off snores. They took it down to 0. And so now we had our quantification, and this is really incredible stuff. And so relative to snoring, the Metabite measures spectral frequency of any given snore, the number of snores per hour, the loudness of any given snore, the loudness of snores by body position, the loudness of the loudest snore, the loudness of the average snore, the percentage of snores in decibel ranges, and those parameters are not measured by sleep center PSGs. Sleep center PSGs are doing it on the basis of the nasal cannula. They're usually not using a microphone, and all you get on a report is the patient snored, period. And so the quality of the information that we get is important, and no one gets this quality, which is important, but it is important to the patient. They listen to that before and after, and they're going to send you patients. They go, wow, I can't believe you did that such a good job for me. That's a referral source. Okay, criteria for successful evaluations. There's subjective criteria and there's objective criteria. So, subjective, patient's comfortable in their sleep. The patient says, I feel better. Thank you for giving me my life back. That's subjective, but it's very good stuff. Patient comfort with their appliance. I won't go to bed without it. I never go to bed without it. Compliance wearing their appliance. The bed partner report. So when you have that patient, we had one, Fred, the other day, and Fred comes in and his wife is with him, and you're expecting, okay, this could be anything. The wife could say, do you know how loud he's not snoring? And the wife says, she brings us a present, I think, because we stopped the snoring and she's back in bed. And so this is really moving stuff when you can do it. And partner report and patient report of excessive daytime sleepiness. And then we have objective criteria. Reduction of snoring by body position, reduction in the loudness of the loudest snore, reduction in the loudness of the average snore, reduction in the loudness of snores above 65 decibels, increase in prevalence of sounds between 40 and 60 decibels, reduction in oral nasal resistance, and compliance chip, which Rick is talking about and he's going to have. It measures the time wearing the appliance.